Good afternoon. Stroke essentially is a disease affecting the blood vessels of the brain. So, every neurologist who wants to treat stroke should have a basic understanding of the blood vessels of the brain and the knowledge and the expertise to read a cerebral angiogram, which is the basic evaluation or investigation for evaluating the blood vessels of the brain. Whether it is a MR angiogram, whether it is a CT angiogram, or the gold standard investigation, which is the DSA, digital subtraction angiography. So in the following few sessions, we will try to read few digital subtraction angiogram pictures and analyze how to read an cerebral angiogram, identify each vessel and identify abnormalities in the vessel. This is an essential knowledge and skill which every stroke neurologist should have. Welcome to first episode. Today we have Dr. Jayashankar and Dr. Fasal who are currently doing fellowship in stroke in Rajgiri Hospital. So tell Jayashankar, tell the story. What is the problem?
The case is of a 72-year-old male who presented with a dysarthria, right UMN facial type of weakness, and he was already started on dual antiplatelet medications.
Ideally, this is not the first picture you should look at. You should look at the angiogram and identify what is abnormality. This is essentially what is, I would call it, forensic medicine. This is you are looking at the damage or the dead tissue. This is the postmortem. You're looking at the damage the blood vessel pathology has produced in the brain. So we'll come to this later. We'll first see what is the problem which the patient has. So what is this picture?
This is a intracranial angiogram, MR angiogram.
MR angiogram. This is a non-contrast MR angiogram.
Yes.
So start reading the MR angiogram pictures.
On the right side,
so this is the right side and this is the left side.
Left side.
So it is like the patient is lying on the gantry and the right side of the patient is what is seen on the MR is the right side. So in some centers they can change this according to in the machine. So you should know, and there will be usually an R mark here and an L mark here. So you should always cross check that. And suppose sometimes they will rotate the image to show a pathology and then take the picture where right will be on the left side. So you should always cross check whether it is which is right and which is left. But normally by rule, this is the right side and this is the left side. Now, the basic principle of reading an angiogram is to follow one vessel at a time. Otherwise, there will be many overlapping vessels because this is a 2D picture. This is not a 3D picture. So, you see one vessels overlapping with each other. We will come to that. Which is this vessel? We will start with this major large vessel which is seen. This is the
right internal carotid artery.
Internal carotid artery dividing into, this is what is this? Middle cerebral,
almost
continuing as middle cerebral artery and dividing into two branches, which is the lower division and upper division. And
behind that we can see PC.
So there should be a PCOM. There should be a A1 segment which is connecting the internal carotid artery to the anterior cerebral artery, which is not seen here.
Yes.
But you see a small vessel here.
Yes.
Understood. Normally you might mistake this for the A1. What is this? So you will have to see, now you forget about that and continue go to the second vessel. Then you will be able to identify which vessel is that. What is this vessel which is seen in the center?
That is basilar artery.
So this is the basilar artery and which is formed by joining of two vertebral arteries. The right vertebral artery is smaller and the left is bigger in size. Which is this vessel which is seen here?
That is pica.
Pica. This is the left pica. But you don't see a corresponding pica here. But what you see here is
that is ICA.
ICA. So this is what is called an ICA-pica balance. If the pica is not seen well, then usually the ICA will be large in size. Whereas here on the left side, the pica is large, so the ICA is small. Then the basilar is normal. You see two vessels arising like this. Which are these two vessels?
Superior.
This is the SCA. This is the superior. And this is what is this vessel which is going?
Left P1.
So this is the left P1. What about the right P1?
Probably arising from anterior circulation via
anterior circulation. So you don't see a large. The PCA is not seen here properly. So what else do you see? So now we'll go to the opposite side. This is the left internal carotid artery dividing into
anterior cerebral.
Anterior cerebral. This is a large A1. So the point from here, from the bifurcation to the division into the two branches or the anterior communicating artery, this is the A1. A1 segment. Clear? So this is the A1 segment and this is the middle cerebral artery. And what you see here is there is a discontinuity here. And in this discontinuous portion, but you can see the inferior division and the superior division. Now there is another vessel which is coming like this and going like this. What is this?
That is posterior circulation.
Posterior cerebral artery. This is a PCA which is continuing like this. So if you follow one vessel at a time, you can easily identify the vessels separately. Whereas if you look everything together, you will be confusing because it's a 2D picture. Now what is abnormality which is seen in the MR angio?
There is a discontinuity
In the M1 segment. M1 is till the bifurcation.
Yes.
So here there is a discontinuity. So what would this be? It could be a stenosis, it could be a dissection, it could be a thrombus, anything. Only thing is that there is an abnormality here. So what else do you see in this angiogram? You look here now in the A2 segment, there is a small narrowing here. Here also there is a small irregularity seen in the A2 segment. So these could be atherosclerotic changes. But never ever make too much of a diagnosis based on MR angio. Even the flow is less, these can be artifactual also. Now, what was done? The patient was taken up for a digital subtraction angiography through the radial route. This is the radial injection. Now, this is the AP view. AP view, and this is the left internal carotid artery dividing into anterior cerebral A1 and middle the M1 segment and the inferior division, superior division. Here, both ACAs are arising from this side. Understood?
Yes.
The A1 is dividing into supplying both ACs because you can see the ACA on this side also. So both sides ACA. So what will happen if this A1 is cut off?
We have bilateral ACA.
ACA infarct. So this is a classical example. Suppose if you occlude the A1 here, the patient will have infarction of both territories of ACA because now the opposite A1 is almost absent. But you can't be sure because the major supply is from here, but it could be a small hypoplastic A1. Suppose if it gets occluded, that might open up. But whether it is aplastic or hypoplastic, it is difficult to say. But obviously, it is not a large A1. It's a very small, it is not seen properly. Now, what do you see here? This is the enlarged view. You can see the proximal M1 and the distally what you can see very clearly, this is a very tight stenotic M1. Then dividing into the superior division and the inferior division is much bigger in this case. Usually the inferior division is smaller, the superior division is bigger. Here the inferior division is much bigger and the superior division is smaller. And what do you see here? These are the small lenticulostriate arteries. It appears as though it is arising from a common trunk just distal to the stenotic area, then forming an arcade sort of thing and then supplying the internal capsule and the basic ganglia. Clear? So what is the angiographic conclusion from this? There is almost a near total stenosis, almost a 95 to 99% stenosis of the distal M1 just proximal to the bifurcation. Do you see any thrombus or anything here? Nothing,
No.
not very evident. No false lumen or anything. And this portion just proximal to the stenosis, it is irregular. And what else do you want to see? You have to see the other vessels also. In lateral view, you can see this lateral view, there is a small narrowing here. ACA. So this could be atherosclerotic. But compared to the MR angio, you don't see that many irregularities in the DSA. That means this is gold standard. That means it is not that significant, whatever you see on MR. MR, you might see some abnormalities like that, but unless it is corroborated on a digital subtraction angiography, don't give too much of significance to that. Always do the venogram also when you're doing an angiogram, so that you can see what is this. This is the superior sagittal sinus, and this is the torcula, the transverse sinus, sigmoid sinus, and the jugular vein. And this is the draining vessels, the cortical veins. So it should be mandatory that even though there is no sign of venous involvement, it is mandatory that the venous phase of the DSA also should be included. Now we look at the postmortem. What damage has this produced? So what damage has it produced? Maybe we know the pathology. What damage has it produced?
It is showing infarcts, multiple infarcts in the first the ACA-MCA watershed area.
So this is a very cortical infarct. in the junction between the AC and MC. This is the
Internal watershed.
internal watershed infarct. And what is this lesion? This is a
MCA territory.
MCA territory cortical infarct. This is not a watershed. This lesion is not watershed, but these lesions are watershed infarcts. So what could be the pathology?
So both stenotic.
There's a hemodynamic component as well as probably there is an embolic component also. This cortical infarct looks more like a embolic event. Rest looks like a hemodynamic event. So this is the way in which, if you have an angiogram, read the angiogram first and then look at the abnormality the angiogram, the pathology has produced. Hope this was useful. If you have any doubts or any clarifications required, please do let us know. We will see you in the second episode of cerebral angio reading sessions. Thank you.